I'm Evangelos Terpos from the National and Kapodistrian University of Athens in Greece. And during the last EHA, the European Hematology Association meeting in Vienna, I presented an oral presentation for a phase 1/2 study of the Greek myeloma study group regarding the dose and schedule evaluation to investigate the safety and clinical activity of the combination of Belantab Mafodotin with lenalidomide and dexamethasone in patients with newly diagnosed multiple myeloma who are transplant ineligible. These were my disclosures. And you all know, of course, that belamaf is an anti-BCMA first-in-class immunoconjugate antibody and is used for the treatment of relapsed refractory multiple myeloma with advanced disease. It has a multimodal mechanism of action. And for us, I think it was important that the treatment of belamaf with pomalidomide and dexamethasone resulted in a median PFS of more than 16 months in patients refractory to proteasome inhibitors, immunomodulatory drugs, and CD38 monoclonal antibodies. So for this reason, we thought that there is a strong rationale for investigating the clinical activity of upfront belamaf in combination with lenalidomide and dexamethasone in transplant-ineligible patients with newly diagnosed multiple myeloma. So here we report the preliminary part 1 data of the phase 1/2 study of belamaf plus lentex in transplant-ineligible myeloma patients at frontline. This is a study design, so the key eligibility criteria included patients with multiple myeloma who were ineligible for transplant with a performance status of 0 to 2 according to ECOG, adequate organ system dysfunction, and a eGFR of more or equal to 30 ml per minute. We used 3 different doses of belamaf of 1.4, 1.9, or 2.5 milligram per kilogram given every 8 weeks. So totally different from the standard dose of 2.5 milligram per kilogram every 3 weeks that is given in the advanced myeloma as monotherapy, of course. And lenalidomide and dexamethasone was used at the standard doses till PD or unacceptable toxicity. The primary endpoint of the part 1 of the study was the BelaRd safety, tolerability, and the recommended phase 2 dose, while the secondary endpoints included the BelaRd efficacy, the corneal adverse event, their management, the PK profile, and the ocular adverse event by the Ocular Surface Disease Index. If we wanted to decrease the dose due to adverse events, then the same dose were given every almost 3 months, or every 12 weeks, compared to the starting dose of every 8 weeks. The patient's characteristics, as you can see, the median age of the patients is similar to what we see in our clinical practice, with a median age of 75 years in the first 2 cohorts and 69 in the third cohort. You see that according to the revised ISS, the majority of the patients had the revised ISS 2, almost 10 to 12% of patients with high-risk cytogenetics. And regarding frailty, and I think that this is extremely important, no patient was fit according to the International Myeloma Working Group, while patients with intermediate fit was the majority, almost 90% of them, and another 10% were frail. So I think that this is what we see in our clinical practice for the elderly population who are not eligible for transplant. So we had 36 patients, 12 in each cohort. And one of the important findings from the initial ophthalmology examination was that almost all patients had some ocular comorbidities. This was also, something that I did not expect, although I had to. I have not seen it before because we have not had ophthalmologic examination in our patients. So you can see that almost all patients had a cataract of any grade. And also there were patients with abnormal fundoscopic findings, almost all of them, and some patients with abnormal intraocular pressure and glaucoma. One patient had an abnormal corneal epithelium, but there was no punctured keratopathy. This one case had stable peripheral corneal staining. You can see here the patient disposition and treatment exposure. As you can see that the follow-up is 6, 9, and 8.5 months in the cohorts 8, 2, and 3. 10, 12, and 10 patients continue on treatment. We had 2 deaths in the cohort 1 and 1 death in cohort 3. These deaths had to do with pneumonia of an elderly patient at the time of the adverse event of 73 years which happened during the first cycle. We had 2 cases of COVID at age 70 and 79 who unfortunately died because in Greece at that time we had not had any treatment available for COVID, especially prophylactic with monoclonal antibodies like Evangelos. Regarding treatment emergent adverse event, I think that you can see here that grade 3 or 4 related to belantamab was found in 6, 2, and 3 patients. But if we see the ocular adverse events, you can see that these were only in 4, 1, and 3 patients had grade 3 or 4 keratopathy, and you can appreciate that in the second group we had only 1 patient with the dose 1.9 milligram per kilogram every 8 weeks. And I think that this is extremely important. If we can see what's happened in all these 36 patients, you can appreciate that according to the visual acuity reduction, we had 4 patients with grade 3 or more in cohort 1, only 1 in cohort 2, and 3 patients in cohort 3. While COVID also was a common event because unfortunately during the period of the study, we had the 5th wave of the pandemic in Greece. Another important finding of the study was the ocular surface disease index. We had a lot of evaluation, as you can see, and if you remember, this includes a lot of questions that the patient can describe. If the patient can read, can check the mobile, can read the computer, or can drive, and you can see that for these specific questions that affect the daily life activities, we had only 2 evaluations corresponding to 1 patient in cohort 2 for most of the time. We had no patient for all of the time, and the same for cohort 1 and 3 for most of the time. And you can appreciate that the majority of the patient, 41, 48, and 51%, had none of the time any ocular problem. While if you can put together the sum of the time and none of the time, 90% of the patient had very limited symptoms from ocular events. You can see here that the relative dose intensity was 77.5% for cohort 1, 80% for cohort 2, and 93.3% for cohort 3. And so we see no significant difference between the intended and the actual dose intensity. More importantly, almost all patients responded to treatment, and you can see that cohort 1 had best response regarding the depth of response, with 25% of the patient achieving complete response or better. But in the second cohort also we had 16.7% of CR and another 25% of VGPR, while in cohort 3 we had 75% of VGPR. So based on this finding, the recommended belamaf dose for the part 2 is 1.9 milligram per kilogram every 8 weeks, because at this dose, grade 3 or more ocular adverse event was observed in only 1 patient. Difficulties in activities of daily living at the most of the time cut off, according to the ocular surface disease index, was observed in only 1 patient. With a median number of 3 infusions, the complete response rate was 16.7%. And the part 2 of the BelaRd study will evaluate the safety and the preliminary activity of belamaf plus lenalidomide and dexamethasone at the recommended phase 2 dose, and will additionally explore an alternative dose modification guideline for the corneal adverse events. I would like to thank you for hearing this presentation. These are my acknowledgement for my colleagues in the Department of Clinical Therapeutics, especially our mentor Thanos Dimopoulos, Tathis Kartistis, Maria Gavriatopoulou, and all our colleagues, Yannis Thanasis, Despina Fotiu, Evangelos Terpos, the Greek Myeloma Study Group, and all the others of the Greek Society of Hematology who participated in this study. Thank you so much.